Welcome back. Today we are going to talk about the vital organs of respiration, the lungs. We'll discuss the features of the lungs and lung roots, the organization of the bronchial tree, segmentation of lungs and distribution of blood and lymphatic vessels among the lung segments. So let's begin. You've already seen the lungs in our lab and probably got an impression that the lungs are shrunken, firm and discolored as these are in cadavers. But the healthy lungs in living people are normally light, elastic, spongy, and they fully occupy the pulmonary cavities. Each lung has an apex, the blunt superior end of the lung ascending above the level of the first rib into the root of the neck. A base, the concave inferior surface of the lung opposite to the apex, resting on the diaphragm. And each lung has three surfaces and three borders. The first one, the costal surface, is large, smooth and convex. It is related to the costal pleura, which separates it from the ribs, costal cartilages and innermost intercostal muscles. The posterior part of the costal surface is related to the bodies of the thoracic vertebra and is sometimes referred to as the vertebral part of the costal surface. The second surface, the mediastinal one, is concave because it is related to the middle mediastinum with the pericardium and heart. The mediastinal surface includes the hilum, which receives the root of the lung and several impressions. We will look at them a bit later. The last one, the diaphragmatic surface of the lung, is concave and it forms the base of the lung, which rests on the dome of the diaphragm. The concavity is deeper in the right lung because of the higher position of the right dome, which overlies the liver. Laterally and posteriorly, the diaphragmatic surface is bounded by a thin, sharp margin that projects into the costodiaphragmatic recess of the pleura. The anterior border of the lung is where the costal and mediastinal surfaces meet anteriorly and overlap the heart. The cardiac notch indents this border of the left lung. The inferior border of the lung circumscribes the diaphragmatic surface of the lung and separates this surface from the costal and mediastinal surfaces. The posterior border of the lung is where the costal and mediastinal surfaces meet posteriorly. It is broad and rounded and lies in the cavity at the side of the thoracic region of the vertebral column. Additionally, each lung has some fissures which subdivide them into lobes. But here we have some differences between the right and left lung. Let's explore these features. The right lung features right oblique and horizontal fissures, which divide it into three right lobes: superior, middle, and inferior. The right lung is larger and heavier than the left, but it is shorter and wider because of the right dome of the diaphragm, which is higher here, and the heart and pericardium bulge more into the left. The anterior border of the right lung is relatively straight. On the mediastinal surface of the lung, we can see the hilum, where the bronchi and vessels enter or leave the lung, and some impressions which show us what organs are in close contact with this lung. The impression in front of the root of the lung here belongs to the right atrium of the heart and is referred to us as cardiac impression. Just above it we have an imprint of the superior vena cava. the azygos vein arches above the root of the lung, and we have the impression of this vein right here. Behind the root of the lung, the esophagus and vertebral column are descending, and we can see these impressions here as well. Regarding the hilum of the lung, the bronchus has thick cartilaginous wall and is easy to be identified. For the vessels, the arteries are always above the veins, and it is true for both right and left lungs. One more structure to mention is this double-layered downward extension of the mediastinal pleura, called the inferior pulmonary ligament. It is a reflection of the mediastinal pleura inferior to the hilum, which continues with the visceral pleura reaching the lung. We have these ligaments on both sides, and they kind of attach the lower parts of the lungs to the mediastinum. The structure is important in surgeries. The left lung has a single left oblique fissure, dividing it into the two lobes, the superior and inferior. The anterior border of the left lung has a deep cardiac notch, an indentation consequent to the deviation of the apex of the heart to the left side. This notch primarily indents the anteroinferior aspect of the superior lobe, and this indentation often shapes the most inferior part of the superior lobe into a tongue-like process called lingula. As you see, both the lingula and cardiac notch belong to the superior lobe of the left lung. On the mediastinal surface of the left lung, we also have the hilum and some impressions, namely the cardiac impression right here, the imprint of the aortic arch, and the imprint of the descending thoracic aorta. The thoracic vertebra make some impressions along the posterior border of the lung. The anterior borders of the lungs lie between the second and fourth costal cartilages. Here, the anterior margin of the left lung moves laterally and then inferiorly at the cardiac notch to reach the sixth costal cartilage. The anterior margin of the right lung constitutes inferiorly from the fourth to the sixth costal cartilage, paralleled closely by the anterior border of the right lung. Both inferior borders pass laterally at the sixth costal cartilages and reach the mid-clavicular line at the level of the sixth rib, the mid-axillary line at the level of the eighth rib, and the scapular line at the level of the 10th rib, processing towards the spinous process of T10 vertebra. The oblique fissure of the lungs extends from the level of the spinous process of T2 vertebra posteriorly to the sixth costal cartilage anteriorly, which coincides approximately with the medial border of the scapula when the upper limb is elevated above the head, causing the inferior angle of the scapula rotate laterally. The horizontal fissure extends from the oblique fissure along the fourth rib and costal cartilage anteriorly. And why do we talk about the surface anatomy? Why do we need it? And you are right if you have the physical examination in mind. We need to know the normal localization of the lungs to evaluate them by percussion and auscultation. Those are important techniques used during physical examinations, which help us to assess the airflow through the tracheobronchial tree into the lobes of the lung. Auscultation of the lungs and percussion of the thorax should always include the root of the neck, where the apices of the lungs are located. When clinicians refer to auscultating the base of the lung, they are not usually referring to its diaphragmatic surface or anatomical base of the lung. They are referring to the infraposterior part of inferior lobe. To auscultate this area, the physician applies a stethoscope to the posterior thoracic wall at the level of 10th thoracic vertebra. The apex of the inferior lobe of both lungs may be auscultated via the triangle of auscultation. Remember, the part of the back where there are no big muscles covering it. Just to remind you, this triangle is bounded by the medial border of the scapula, by the inferior border of the trapezius, and by the superior border of the latissimus dorsi inferiorly. On this image, you can see that the inferior border of the right lung is a little bit above than the lower border of the left lung. Is that normal, or something is wrong here? How do you think?